and then
Sure.
she takes the panel from there.
Sure. Okay.
Yep.
Yeah.
Okay, good afternoon, everyone. A warm welcome to one and all present here. It's an absolute pleasure to welcome you all to the last and the best Empower Hour of the year. And before I could introduce you to the moderator and panelist for today, I request Madam Kavaljit Oberoi to give us a brief introduction about what is Annie and how Annie takes up these initiatives. So over to you, Kavaljit, ma'am.
Thank you, Durga. Of course, by now, everyone, I think most of the nurses in India know about ANEI, Association of Nursing Executives of India. We are very fortunate. I must say that we are very fortunate to have this association in India led by stalwarts and led by people, who are like Tankam and Ajita and Colonel Usha and everyone around, who are leading this. So it's a platform where each of the nurses can have a voice. I mean, you won't see this in many of the places, but here you can have a voice, and it's a very professional organization where not only having a voice, but you are able to learn lot of things. So Empower R has been one of the platforms where every month we have been conducting sessions, and this year our theme was AINA. AINA meant Association of Young Nurses. You can hear me anyway? Okay. Association of Young Nurses, where we had said that this year the theme would be anything the state thinks they want to talk about. It is their burning platform, their association, their problems. But the idea was not to just get all the experienced or experts talking about. We can also involve student nurses and young nurse leaders who become a part of this panel. And I must say that this has been a wonderful session. We had lot of wonderful topics. Everything is uploaded on YouTube, and you people can go to a ANEI website and you can see the topics, the programs, the what each of the nurses, the young nurses, the way they have expressed themselves. And I'm sure this team in Maharashtra will also do a wonderful job on this. Right now, we have also divided this into 4 regions. So in Maharashtra, Miss Elizabeth Joseph is a regional head now, and each of these states or the regions would also have chapter heads under them. I would only say that all the people who are participating in this, if you are not a member, please become a member of ANEI. You will gain a lot from that. Thank you so much, Durga. You can take over. Wish you all the best.
Thank you, ma'am. Thank you so much for giving us a introduction to Annie and how Annie works. Without wasting further time, I take the pleasure and honor to introduce our moderator, Miss Prajakta Hindrekar. I'll just spotlight her for everyone to see. So, Ms. Prajakta Hindrekar is currently a PhD scholar, and she has a vast experience of more than 27 years in healthcare system. She was in US also. She is a graduate, postgraduate, and a IAEBP fellow, and she has been in the healthcare system for a long time, an internal auditor also for NABH, a Six Sigma Green Belt, a general secretary, and at a position of general secretary with CCNS India. So we have an highly experienced person who is over here who is going to moderate this very important session of what we call as fear of unknown, a threat to patient safety. So without taking further time, I will hand over the session to Ms. Prajakta Hinlekar, and a warm welcome to all our esteemed panelists who very readily agreed to be a part of this important panel. A warm welcome to each one of you. And on behalf of any Maharashtra chapter, I take this honor to welcome you to this session. And I would also like to introduce my office members of Maharashtra chapter, Miss Shubhangi Jadhav. She is the Vice President for Maharashtra chapter, and Miss Sheetal Kamre. She is the Secretary for Maharashtra chapter. So whatever activities Maharashtra chapter does is impossible without the support of all the official members. And now we are being headed by the zonal team also, which comprises of President Dr. Elizabeth Joseph, and we have Miss Minimol Verghese, Dr. Shobha Gaikwad, and Miss Tripti Nanda, who join our zonal team. So a warm welcome on behalf of all our office members. So over to you, Miss Prajakta.
Thank you, Durga, and thank you, Annie, for this opportunity. and we have illustrious panel. So today's topic is fear of unknown, and I think fear of unknown is the greatest fear of all. Fear thrives in the absence of understanding. So today is our effort with our illustrious panel. I take the pleasure to introduce each one of them. We have Miss Rajashri Vise with us. She is a clinical psychologist and psychotherapist. We have Savita Manvel, who's a nursing quality coordinator, Jupiter Hospital, Mumbai. Then we have with us Dipti Vairkar, who is an infection control nurse, Tata Memorial Center, Kharghar, and Miss Bincy Thomas, who is nurse educator, Fortis Hospital, Muller. Once again, I welcome all the delegates who have taken time and who believe that we can learn, we can revise, which we have already learned. Our teachers have worked on us. So today is our effort. How can we help our patients? How can we empower our nurses to know more about fear of unknown? So we have very esteemed panel members who's going to enlighten us and empower our nurses today so that we can make life of our patients and family better, and they can pave their journey towards better health. So my first question is to Miss Rajashri. She has got more than 25 years of experience in understanding patient psychology. She is a psychotherapist. So, my first question to you is, how are you going to enlighten or ensuring that our nurses are aware what exactly is the fear of unknown and what could be the possible reasons behind it, and what are the qualities that a nurse should develop to address it? Over to you, Ms. Rajeshri.
Good afternoon, everyone. Thank you once again for inviting me in this program. And thank you, Prajakta. To begin with, fear of unknown with respect to the patient safety, right? Um, Imagine a situation where we all are going through a unknown place, a new place, okay, and our all Google Maps are started has no network, and whatever network it has, it is giving us a very wrong signals or wrong notifications. How would all of us feel then? Okay, being an online session, I may not get an response, but I mean, people can keep on messaging, and without taking much of the time, we all will feel lost, right? We all will feel lost. Where are we? We will be scared. Are we on the right place? Right? So, fear of unknown is basically we humans have a innate tendency that we should have certain certainty about where we are, what we are doing, what will happen to me. We all like to have the predicaments. Like, even wherever we go, अभी आगे क्या होगा ये अगर हमें पता चलेगा, we are at ease, we are at peace, or we want things to happen the way we expect them to happen. And if there is certain mismatch in that, then fear is a natural response that we give as all human beings. So fear is very natural. Number one, if it persists for a longer time and it stays, then that comes into psychological issues where zarurat se zyada chinta karna, where there is excessive worry. It is called as anxiety. So fear is a natural response. Once we are comforted with the logical answers, as a human being, we are sorted out, we are comfortable. But fear, especially when it comes to the patient safety part, already people have read a lot these days. There are more Google doctors than actual patients, right? Secondly, when a person is not in a stable physical or emotional state, obviously the thinking capacity is um, not up to the mark, or there is a tendency that a person might think more irrationally than the rational things or logical things. And fear is something also which is perceived threat. So a threat which may not be actual threat, but the patient may see as a perceived threat. So all these things are fear of unknown, right? Secondly, you also asked what are the qualities a nurses should possess, right? Number one, to empathize with the patient. How would you feel if you were in his or her place? Okay. Secondly, if you are able to relate to the patient, if you are able to understand, and if you are able to identify exactly what is the fear about, things become much more easy for any person. Because you may think a patient is particularly fearful about something, but you need to ask and talk to the patient what is exactly bothering you. So empathy is one. Observation, I think the 6 C's of nursing, we all know that. So I'm not going to repeat that. But from a psychologist perspective, many times this matters a lot about having a clear communication, having a good listening skill. It is not that we should listen to what we want to hear. It is about to listening what the other person, especially the patient, is saying, and being a part of the entire team when it comes to patient safety and patient care. There also has to be a clear cut communication with all the team members. Secondly, nurses should be aware of certain difficulties or certain conditions, medical conditions, so that they can also be a part of the information giving. Lack of information or extra information is something, or there are a lot of myths and misconceptions that people may carry. It could be even with doing a simple blood test, right? So we need to understand first where is the patient coming from, and for that one has to have a lot of observational skills, overall patient's behavior throughout, since the time of admission till the time of discharge, his or her interaction with the family members. Secondly, what is the basic knowledge or idea or his definitions about the process that he or she is going through. And you, if you are, language skill is one of the best skills. The more languages you know, it becomes very easy to communicate with that person, even if it's a minimal interactive language. But you know, it matters a lot. Secondly, one has to see a very positive approach when it comes to dealing with patients, even when listening to the patients. You may give an appropriate information to the patient, but with what approach are you giving it? That also matters a lot. So these few basic skills, and one has to keep on improving on all these skills on everyday basis. It's not कि अभी आ गया तो अभी हो गया. We all are students and we should always learn and keep on learning and keep on implementing that. So empathy, clear communication, knowledge about your own role and different conditions, especially if you are into some special ward. Hello?
Go ahead, Miss Rajashri.
Yeah,
We'll
yeah,
mute.
yeah, yeah. So, clear communication, empathy, the patient should be able to relate to you and you should be able to relate to the patient, and basically understand where is the patient standing when it comes to certain procedures, information, or what has happened to him for whatever reasons he or she may be admitted. It could be a simple illness to a major surgery. Yeah. Any questions, please feel free to post them in the chat box. Also, we can also address them in the question answer session.
Sure, Dr. Miss Rajashri, for that answer and enlightening our nurses. My next question is to our first panelist, that is Savita. I mean, the next panelist. Savita, will you help us to understand what are the practical tips to frontline nurses? Like a patient comes, or you know, he or she feels "मैं कहाँ आ गया?" And I think we have learned in our Maslow's hierarchy of needs. First is physical. Everything that they need, if they are aware, I'm sure they will be at ease. Now in the era of this where they google, some hospitals have their hospital rooms where they can see, but yet a good orientation, I think the first interaction where the nurse is orienting, if you do well there. So can you share us what are the practical tips that nurse should follow, so that that first interaction becomes a, what to say, a good relationship that nurse can build with patient, and patient is also at ease.
Sure. Good afternoon, everyone. And thank you, Annie, for giving this opportunity. Thank you for the question, Prajakta ma'am. So, yes, when we talk about empowering nurses and patient orientation, it requires a good communication. There has to be clarity. When the nurse is aware about what is to be done, so automatically there is a confidence that is built up, which is very much essential. When there is an admission, so there should be no rush, like we receive the patient quickly, we just check the vital signs and we just tell the patient you need to know abcd, a list of things are being just said. We need to ingrain into the nurses that patient orientation should be done very rightly, as it is the first intervention that we take when we talk about patient safety. So we need to encourage on focusing on the first 5 minutes. As ma'am you rightly said, it is the first impression. We say it is the lasting impression. So being the first interaction, the patient orientation, it shouldn't be a checklist driven. It should be more of a dialogue. It should be a moment wherein there is an active listening, there is an understanding. Depending on the understanding, the nurse will be able to give the right response. When we are giving the right response, the patient develops a trust, and it also makes the patient feel more important and comfortable. So first is we need to encourage on focusing on the first 5 minutes that we interact with the patient. Second, I would like to say is reinforcing on the identity, identifying the self and the patient. This has to be re-emphasized. Now, we are not sure whether the nurses would do or no. We train them, we keep on reinforcing them. But as nurse leaders, even we can, on our rounds, ask patients if they know the name of their assigned nurse. So this will help us to understand whether the nurses are doing the identification protocol. Third is to emphasize on using simple languages, avoiding medical jargons. We can create standardized orientation practice. We can create certain verbatums which can be very handy, especially in like we have like the nurses are under stress because of the multiple shifts and all. So they may not be able to focus on one particular. They may miss on certain things on orientation. So if we have a created verbatums or a scripted orientation script, so that will be very much helpful. Now what we do is they do educate at the time of admission during the orientation. There are a lot of things that the nurses, just as a part of the process, they just go ahead and at the time of admission they just bombard the patient with those education or the things for the safety. But at the time of admission, the patient is in distress because of the disease condition. The relatives are in anxiety, they are anxious, they are disturbed. So we need to the verbatins that we create for orientation. We should just specific points should be focused on. That is orientation to their environment, their safety, how they can prevent falls, how they can prevent any de-linings and all. So we need to create it, as ma'am said, Rajeshri ma'am, about showing empathy. So we need to use liners that your safety is important to us, and then we tell them about what safety measures they can also help in taking so that they prevent the falls. Need to focus on or tell them information about what are the visiting hours, whom they can approach for any help required. So when we create verbatins, we need to focus on only specific points at the time of orientation. And we need to encourage on teach back to ensure that there is understanding. Rather than asking the patient, did you understand? We can ask it in a better way. Can I just know if you have understood what is being like told to you, or what is the information you would pass on to your next relative who would be being with you about the safety measures that we have told. So this teach back, it helps us to bridge the gap between hearing and understanding. Very much important is making the nurses understand the rationale behind patient orientation, how this simple orientation process, if done in the right way and given the specific information, it can help us to prevent major mishaps. It isn't just, we need to ingrain that it is not just paperwork, but it is the first line of defense against the clinical errors. And very much important is about reorientation. There should be no assumption that once that we have given the information, even for us, though we have trained the nurses, we need to reinforce, retrain them. So similarly, they also need to ingrain that the information should be repeated. Though it is the same relative with the patient, still we should not assume that they would remember everything. So during shift changes, during transfers, post any procedures, or once a patient has maybe received sedation and the patient is out of sedation, so again, reorientation should be a practice. Finally, reinforce and appreciate the good practice. Somewhere we miss on appreciation and recognition. As leaders, when we take rounds, when we see bedside rounds are be taken, we interact with the patients. So with there, we can also get to know if a particular nurse has deeply connected with a patient. So we need to call it out. That nurse needs to be appreciated. If the patient tells about a particular nurse, the good practices. So that needs to be, maybe we can have huddles, quick huddles before the shift. And we can just again share this best experiences that the patient has shared. So it can be a motivation for the others also. So to conclude, I would say one is to focus on the initial 5 minutes, make the nurses understand the reason why orientation is important, and ingrain in them that it is the first intervention for patient safety and the organization safety. Thank you.
Thank you, Savita, for that elaborative. I'm sure the young nurses will benefit. I think there is echo. So I'm sure those who are seniors, those who have joined, they must be remembering their clinical posting. You know, that one patient who remembers who they met first in the hospital and how they were very comfortable. And they are so grateful that that particular nurse really was very compassionate. She spent a lot of time, and how the transition from home to hospital was smooth. My second question is to Dipti. I'm sure we did lot of efforts to ensure that the orientation was good, but I'm sure there are some not so good things also may happen. So if you could just tell us that what could be preventable if you are ensuring that the patient orientation is all gone well, and some of the best practices that you have seen and that has worked when the orientation goes well.
Yeah, thank you, ma'am, for the question, ma'am. And before moving towards the question, I would like to thank the Annie for creating this platform and providing opportunity to us to express our views on this sensational topic. And moving towards the question, I would like to give answer in the three part. The first part is what are the preventable incidents which we see in the hospital setup. So if you see the patient worry, anxiety is basically exacerbated when the poor patient orientation is there, when you don't orient the patient properly. And this poor patient orientation is basically seen at the 4 points. That is, first, at the time of admission of the patient. Second, when we transfer the patient to the another unit. Third, it can be seen post-procedure when things are not properly explained. And the fourth, it is also seen at the time of discharge. Okay, and you see certain incidents during these period. That is, first is immobility. So immobility, it can be range right from the simple immobility of the limb where you have insertion of IV line. So it can be complete immobility when the patient has drain or follies and other things. Okay, especially these things happen when pre-procedural explanation is not given to the patient adequately about the post-procedural status of the patient. And out because of this, out of fear, sometimes patient hesitate to move, or sometimes they will not change the position when the early mobilization is required. And especially in the setup when we have poor nurse patient ratio and you have this type of problem of the patient with orientation, it can lead to the certain complication, and this can lead to the pressure also because of prolonged immobilization. Second thing is in non-compliance to the medication regime. That is because of fear of hospitalization, which is added with the poor patient knowledge, can also lead to the non-compliance to the certain important medication regimen. Like, for example, non-compliance to the completion of the course of tuberculosis because of unexplained side effect. It can be there for the simple course completion of the antibiotics also. If things are not properly explained, and out of fear, sometimes patient will not continue the medication because of the fear of side effect. Third thing is aggravation of the symptoms. So here this can be seen basically in the patient who are chronic patient, like cancer patient and all. And here out of fear for the long-term patient, sometimes we can see psychosomatic symptoms in those patients like insomnia or increased level of pain. And sometimes you can see the agitation in the patient. And this is most commonly observed in the ICU patient. And out of this agitation, sometimes we can see there is a self-extubation, the removal of IV line, the removal of drains. All these incidents can also be noticed. Uh, Last, we have inadequate adherence to the discharge instruction, because we have seen in the initial part only, because at four uh, points we can see this fear. So at the point of discharge also, when the patient goes home, and if the proper discharge instruction and orientation is not given to the patient, like how the patient has to be taken care of after the discharge, then again this can lead to the certain complications. For example, suppose after the breast surgery, after MRM, we discharge the patient on the second or third day, and after going home, at the time of discharge, we give all instruction, like you need to take medication on time, like follow up on time, and you have to take maintain personal hygiene. But if you fail to explain certain minute details, like the wound has to be cleaned thoroughly with the soap and water, and it has to be tapped dry after this on the second or third day, and if you fail to explain all these things, once the patient goes home, sometimes because out of fear, they will not touch the wound at the time of taking bath and all, and again this can lead to the further complication like infection after the discharge, and this can be notified on the first day of or on the first follow-up rather than during the discharge period. So these are the few preventable incidents which we can see in the hospital setup. And second part is the certain best practices. If you see best practices in general, I think Madam has already enlightened the things very well, like communication and other things. Just to add on it, first thing, I just wanted to explain about relaxation technique. So along with the communication, education and all, if we know the patient is in stress or in fear, we can provide certain simple relaxation technique to the patient, like deep breathing exercises, or we can also provide the music therapy to the patient. Okay, next we have supportive presence, like simply just be with the patient, hold the patient hand. This can reassure the patient and calm the environment of the patient. Then next thing, we can have comfortable environment or environmental modifications, like here provide comfortable environment and minimize the stimuli. Basically, when for this patient, those patients who are on monitor, if you attend the monitor alarm promptly, and this and reduces the stimuli, and this can also make a great changes in the patient fear of the environment. So these are the internal practices, and just quickly I just want to explain few practices, best practices in my hospital which we follow. Starting with the first infection control counseling, which we do for the pediatric patient parents. So here we all know the cancer diagnosis is very devastating. So what we do for a pediatric patient's parents, we give infection control counseling on the first visit to the hospital in the OPD, and we continue this counseling for the three setting, that is after 15 days and after 1 month. And we explain few things in detail, like what is cancer and how to take care of the child, about few things about diet, treatment modalities, then certain insertion of lines which are there for the child for the course of treatment, like PSCC port and all. And because of this explanation, parents stress level goes down, and they can face a further course of treatment comfortably. Second thing, we have participatory care. The participatory care, it is care when we involve the patient and the patient relatives in the care. Okay, so here what we do when we shift the patient from ICU to the ward after the certain surgery, like especially after head and neck surgeries, we teach a certain procedure to the patient relative on the first day when we take the patient in the ward, and it is taught by the staff nurses in the surgical ward. And here we teach them about hand hygiene, mouth care, we teach them about rescue feeding, and how to give bath to the patient after the operation. And slowly, these things are done by the patient relative under the supervision of the sisters. And slowly they gain the confidence in those procedure. And by the time of discharge, they can do the things with the patient independently. So here, because of this participatory care, the patient and the relatives feel relaxed, and here the fear of this unknown can be reduced. Next thing is the last is a comprehensive teaching. As a comprehensive teaching throughout the hospital course as well as the time of discharge also needed. So for certain patient like who are highly dependent patient, like in our setup we have BMT patient who are highly dependent throughout the course, and so at the end of so towards a discharge, we start giving them discharge instruction. It is not given directly on the day of discharge, but we start the instruction prior to the discharge. So we give them discharge instruction in three settings. First two settings, we explain the instruction to the patient and the relatives. And the third setting, we ask the relative to to repeat the instructions. And so that with this, we confirm that everything is understood by the patient and they can take care of the patient at the home setting. And last but not the least, like we all know the nursing care cannot be replaced by any other profession. But still, the second important fact is that the nurses cannot reach each and every point of care of the patient. So sometimes we can take professional helps, that is trained professional helps can be taken for this counseling setup. So here in our hospital, we have, at Rec Hospital, we have trained navigators called as a pivot and who act as a patient guide during the course of the treatment. And here they give counseling to the patient, explain the certain procedure to the patient whenever it is needed, whenever it is referred to them. And if you see in our setup, we receive the patient from all over the India. So about 60% of our patients are out of Maharashtra state. So these keywords are also taken from various states so that this language barrier can be overcome. So this is from my side. I hope I have answered the questions. Thank you, ma'am.
Thank you, Dipti. I'm sure all those best practices that you're following, because you work in a specialized hospital which is for cancer. We'll move on to our next panelist. I can relate gave a feedback, her experience that she shared. Most of them are totally unaware, especially elderly. The only thing she liked was the information that was shared before even asking. So sometimes we say you ask and you shall receive. But in the hospital setup, the fear is so much. They don't want to upset the caregivers, all the healthcare professionals also. So my next question is to Binsi. How do we ensure that patients and families are informed about what is happening and the wait time? Especially, I think most of the hospitals are tracking wait time or response time by the healthcare professionals. What are your thoughts that sensitizing our frontline nurses on prompt response to queries and clarifying doubts, which will also contribute in minimizing or reducing the fear of unknown? Over to you, Binsi.
Thank you, ma'am, for the question. So, it is a very relevant concern that touches the core of patient safety and experience. So, few of the measures that we have in place to sensitize nurses for effective communication, I'll just mention. So, when a nurse enters a unit, we definitely, all of us practice nursing induction. We also have something called as a communicating care is delivering care module, which happens for 3 days, which specifically focuses on aspects of communication, in which evidence-based tools like AIDIT and LEAP is used for, especially for patient interactions. So AIDIT is a tool which speaks about like acknowledging the patient, giving your introduction, then explanation, duration, thank you, etc., which is taught for a whole day to the nurses. It's in the form of role plays and it happens in the classroom setting. And we also have certain mandates which we mention in AIDIT, like while you come out of the patient's room after your interaction, you have to definitely ask about, is there anything else that you need? So this happens when it's a routine interaction. We also train the nurses on how to handle a patient when it's a difficult interaction, like a patient is in pain, is angry about something, is complaining, is dissatisfied, etc. So we use the evidence-based tool called LEAP, which talks about listening, empathizing, apologizing, and providing solutions. So again, this module is not like a 1 hour classroom training. It's an entire day goes into training the nurses on these modules, and in a role play method is used. Especially the listening part, we take almost half a day to sensitize nurses on how we are not good listeners. and how to do effective listening. So listening, we tell them about how to not only paraphrase whatever the patient is talking, but also try to understand the needs and the feelings behind what the patient is telling. For example, if the patient tells the nurse that I have not got food since the past 1 hour, so the nurse has to paraphrase as, what I hear you say is, you have not got food since the past hour. I know you must be hungry and you're really upset about it. So the nurse has not only heard what the patient said, but the nurse is also understanding what is the physical need of the patient as well as the feeling behind that need. So this way the nurse learns to empathize on the patient. So in these role plays, each nurse gets to act as a patient relative, as a nurse, and also as an observer who observes from outside what's the how effective the interaction was. So naming these emotions are important, and each nurse gets to be empathetic by being in the shoes of the patient as well as the patient relative and trying to understand their needs. So these evidence-based tools help in effective communication. We also let the nurses go to the clinical areas. It's called as a passport activity, where they get a passport to actually implement the aspects of AIDIT onto the actual patient and then understand what are the deficiencies and bring about improvement in that. We have refresher sessions on CCDC. We have refresher sessions on multiple kinds of communication. I'll not go into deep because of the shortage of time. We also have measures in place for tracking the efficiency of the trainings that we provide. For example, in the ICUs, we have daily ICU communication, which is tracked. Our benchmark is more than 95%, and we are currently at 96 to 97% compliance to daily ICU communication, where the communication happens between the ICU team and the bedside nurses also involved. And during rounding times, each relative is called inside into the ICU, and the discussion about the patient's condition happens within the ICU. There are many other measures like these, like having visual cues in the department where the nurse's name is mentioned, the doctor's rounding time is mentioned, the visiting hours of the doctors are mentioned, which helps the patients become better, take decisions better because they are informed well. So these are few of the aspects that I would like to throw light on.
Thank you, Binsi, for being crisp. We would go now to Dr. Rajashri. If you can enlighten or tell us that how do we help our patients and families to manage fear of unknown, also in cases of different age groups or different conditions like psychological issues, patients those who are aggressive, patients those who are with neurological conditions, or patients those who are in critical care units. Over to you, Dr. Rajashri.
Thank you again. So, the basic, and I would be emphasizing on this factor repeatedly. How would you feel, or how would you want to be treated when you go to any place, especially in the hospital? The first thing that what you need to do is you need to acknowledge the patient's emotions. What just Binsi ma'am just said right now, that rephrase and do ABC things. Of course, yes, but understand and acknowledge कि I have understood. It's not कि नहीं नहीं ऐसे कुछ नहीं होता, इतना दर्द होता है. No, the patient will say, no, I have that pain. You don't know. आपको क्या जाता है बताने में, right? So the important thing is, yes, I understand you are in a painful condition, or I understand that you are anxious about doing certain tests. You would want to know more about the test. So all these things are important. And when I'm saying this, we all have to stick to our roles, right? One ma'am just said that yes, it becomes very important at times to hold the patient's hand. But then when doing so also, you should identify and highlight that we are in a patient nurse relationship, or we are in a patient psychologist therapeutic relationship. Sometimes people may cross that line, or sometimes the patients may develop a dependency on you, right? No, whenever I am fearful, this particular nurse comes to me and she comforts me. I feel better when she's. That's a great compliment to the nurse. You are doing a good work, but also make sure that there doesn't have there is no dependency that the patient has on you. These are minute things, and very important things as well, right? I'll give you quick two examples. When I was working at JJ hospital, there was I was in the pediatric department, child guidance center. So there was this approximately 7 to 8 year old girl who was extremely scared of doing a blood test. she had come to our department. There was an important routine blood test, but with certain urgency also. And she had literally pushed all the lab technicians, including a senior doctor. Imagine a 7 to 8 year old. So when she was brought to me, she was all crying. She was extremely fearful. And to add to that, everyone, her family members were scolding her. So she was again scared कि मेरे को सब लोग डांट भी रहे हैं. So the first thing was acknowledging the fear. Second thing, there has to be a presence of mind with each of us. I just took a safety pin there, which was there. And I just showed it to her, demoed it to her that this is how it will prick. So I first showed it to her on my hand. Then gradually I just halka sa I pricked it onto her. This is what it will feel like. And I think ये मूंगी काटने जैसे तो आप कर सकते हो, right? And then after comforting, after acknowledging the fear, and after giving her the confidence that even if it will be painful for few seconds, you need to just give it a try. And नहीं हुआ तो हम फिर से देखते हैं. And don't force, but leave her with that option that it's okay, but try करके देखो. After half an hour, the same girl came to me smiling, and she showed to me her, blood test का hand कि देखो डॉक्टर मैंने कर लिया. So lot of things that we also need to have presence of mind and show it to the patients. There is one more, recently one of my patients who had neurological conditions because, he had psychological conditions because of the neurological changes with respect to 65 age. And he was asked to do an MRI. He had been to 3 different MRI centers, very fearful of actually going into the MRI, and he had come down thrice, three, 4 times. He had gone in on the table and came back again halfway. So it was very difficult for the doctors also. At that time, again, the patient was counseled appropriately, and he was given an exposure to the MRI when done with other patients. So these are certain things. One of the ma'ams also said that you have to call up appropriate professionals if required, psychiatry or psychologists, to counsel the patient. Secondly, acknowledging matters a lot. Also, as a nurse or any professional working with patient, we need to understand what to communicate, how to communicate, and also what not to communicate. And for that, one has to always coordinate with the treating doctors, whoever there. At times, there are multiple doctors who treat a patient, and patients will keep asking you, वो डॉक्टर क्या बोले, उसने क्या कहा, उन्होंने क्या कहा, आपको क्या लगता है, आप बताओ ना, ये ठीक होगा ना, नहीं होगा ना. All you need to highlight is, I just know this. आपको क्या बताया? What is it the doctor has said to you? Just give a patient listening, assure कि हाँ मुझे इतना पता है, बाकी आप डॉक्टर साहब से पूछिए, और I will put this question to the doctors and update you, and leave it at that. The patient feels heard, that my questions are at least taken into consideration, and they will give me some answer. This matters a lot again. Also, when it comes to treating family members, number one, identify who is the decision maker in that family. Many a times, the visiting relatives, there are too many things. I know I am taking a bit long, but I will try to cut it short with 2-3 more points. Identify who is the decision maker, because there are many relatives who keep on asking, keep on sharing things, and you don't know ultimately patient के लिए decision कौन लेने वाला है, and who is it that patient stays with the person. So sometimes they stay at different places, someone else brings them to the hospital. So these things are also important. Again, I will emphasize the point I had made in the beginning. You need to be well acquainted with the conditions and what could be the possible symptoms or behavior, especially when it comes to psychological and neurological issues like dementia, etc., etc. Many a times there are patients, they are not told about the surgery before. So you need to understand with the treating doctors what is the information given to this particular patient. And because there is a systematic way, I was called to tell a patient about that he is going to go for a bypass surgery, and he was absolutely scared and not willing to do that. So many a times you also need to get updated with your, and that's a teamwork. That is patient ko, all the treating doctors, how much of information is provided and how much are we supposed to provide. And if at all it is supposed to be done, How much in our role can we inform them? With children, it has to be especially very careful, very cheerful, and again, the same way as we deal with the adults, that acknowledging being with them, answering any question, being with that patient, may it be a child or adult, also helps a lot. And sound mind in a sound body. We all are human beings, so we all also get stressed, we all also feel sad, angry, irritated. Many a times, for example, patients who are having OCD, etc., obsessive, there is a compulsive need to ask questions repeatedly. Or in patients having Parkinson's or dementia or Alzheimer's, they forget that I have asked this question, and they will ask these questions repeatedly. So as a healthcare professional, we all have to have lot of patience, lot of tolerance, be very receptive at times even to their harsh remarks, understand that they don't do this deliberately, but then wherever needed, take help of the family members also, or take help of the psychologist, or a quick tips कि आप है ना uncle या auntie, आप लिख के रखो कि आपको क्या चाहिए. So again, presence of mind also matters a lot when handling certain questions. um, with violent patients, never get panicked or never get scared. Even if you are scared, don't show it, and that really helps. And your safety as a healthcare professional is also important. So understand, again, speak to the respective professionals to what level this aggression might go, whether a child or an adult. I'm referring to both the cases, even with the relatives at times. So you can take someone from the admin department also, that this person is very whatever, rude or arrogant, or is never satisfied with whatever we tell, can you please intervene? So again, the hierarchy, the teamwork that you all have in your respective hospitals, please be aware of that. And if you are stressed, how can you help others? How can a person give comfort to a person who is scared when he or she himself is scared? आप खुद डरे हो, आप बोलोगे कि नहीं नहीं डरना नहीं है, will you be convinced in convincing that person? So you have to be, and it's okay if at times you're not able to handle certain situations. Be honest and talk to your team or seniors that at least with this patient, maybe I will need some help, or I would want someone to be with me, or with this patient, can you send someone else? And it's absolutely okay. There is nothing wrong. You don't become incompetent in that. But keep on learning through other experienced people and get updated and equipped again. So I think these are a few things. And last but not the least, you have to be always hopeful. Never lose hope in any case, for any case. That matters a lot. Even for terminally ill patients, we do understand severe cases where, in the ICU, we know कि बहुत chances कम भी है. Don't lose hope. You never know what can happen, because every patient's response to every treatment is different. And this is an important thing. Also, one of the important things that I missed earlier, many patients have different negative experiences from different professionals or different setups. So उसमें किसी का दोष नहीं होता. Sometimes there are all good things, but the patient may perceive it in a negative way. We never know that. So understand where is the patient and the family coming again. If you understand that, you also need not generalize कि ऐसे negative ही होगा सब. However difficult the situation may be, never lose the hope in any case. देखते हैं, देखेंगे, patience रखिए, कुछ ना कुछ हो जाएगा. Focus on the minutest positive changes in daily recovery of the patient, may it be OPD or ward cases. For example, fractured hand है, तो पहले उठा भी नहीं सकते थे, अभी सिर्फ फिंगर मूवमेंट्स हो रहा है. Ask the patient to concentrate. See, yesterday you were not able to even lift the hand, today at least you can move the fingers. Small things. They will focus on reporting the complaints, listen to them, but you bring them back, see the improvement. See the improvement. Slow and steady wins the race. Be patient. We are there with you. And that assurance and reassurance definitely helps. Thank you.
Okay, yeah. Thank you, Dr. Rajeshri. I think the passion was flowing in your answer, but we'll have to move on because we don't want delegates to have fear. How long we have? When will it get over?
Absolutely.
So my next question is to Savita. I think however brave the patients are, whenever there is a procedure or whenever there is, some event, they get fearful. So how do we ensure that, before, during and after any procedure, how do we insist or how do we prepare our nurses to be very consistently paying attention to those details or change in patient behavior and spot a fear of unknown and help or intervene?
Sure. Thank you for the question, ma'am. So, patient comfort, it's basically is an indicator that the patient is safe, patient feels dignified, and it's a good quality of care. If the patient is anxious before any procedure, if we do not give proper explanation, and if the patient is anxious and there is something which is affecting the patient, it can affect the patient's vital signs. The patient will not be cooperative, and it can also further affect the recovery. Hence, giving timely explanations at each step is very much important to gain the patient's confidence, cooperation, and also help in the patient's recovery. So, that needs to be explained thoroughly to the patient. Here, I would like to give a mnemonic care where C stands for comfort and consent, A stands for anxiety and analgesia, R for reassess during procedure, and E to evaluate after procedure. While talking about comfort and consent, even if it's a simple IV cannulation, how many times do we actually ask the patient, is it okay to I need to put an IV cannula or I need to give you an injection? So do we really ask the patient, can I do it now or does the patient need some time? Do we even explain even a simple blood collection? For us, it's a routine procedure, but for a patient, many times it can be just a first time. So they may be very much afraid of just that simple needle also. So explaining to them, even if it's the simplest procedure, we need to explain. Next is ensuring privacy. We just, if any procedures, they become very conscious when we are doing procedure. Again, it's a routine for us, but performing, they would be seeing if there is anybody looking at them. So ensuring privacy is very much important even for a simple procedure. And we need to confirm whatever is explained to them, whether they understand and whether they give consent for them, so their consent is very much important. Then A for anxiety and analgesia. So we need to identify if they have any fear, if they are anxious. We need to ask open-ended questions. As nurses, especially young nurses, many a times we feel they are performing low. So when we talk to them, they expect that somebody should talk to the nurses, somebody should ask them. We also listen like simple thing. कोई हमसे ये भी नहीं पूछा है कि हमने चाय पिया है कि नहीं, हमने खाना खाया है कि नहीं. So being a professional, we expect that. So similarly, we should even think that our patients are relying completely on us. They are trusting on us. So timely identifying whether they are having any anxiety, they are having any fear, anything they need a clarification. So that needs to be identified and addressed. And if it's a procedure, we need to check if they are in any pain and the pain needs to be assessed. And then we need to give them a reassurance that everything will be taken care of. Then coming to R is reassess during procedure. Before procedure, we do a check whether the patient is ready for the procedure. After procedure, we do a check whether the procedure was done properly. We check the vital signs. But what during procedures? During the procedure, also, we need to observe the verbal and non-verbal cues. Observe the patient's facial expressions. Check for the vital signs. Check if the patient is having any discomfort. If there is a requirement, if the patient expresses concern, that they need some position change, some adjustment, some support. So we should pause the entire, it's a teamwork. So even we can escalate to the doctor that can we take a pause and maybe we just don't rush to complete the procedure, but take a pause, see that the patient is comfortable, and then proceed with the procedure. Then coming to is evaluation after procedure. We do this quite often. There are certain timelines that we follow, but most of the times when we see about evaluating after procedure, we just check if the patient is having any pain. So the pain is reassessed. We check the vital signs. But are we also checking for the patient's comfort? Is again the patient, the position is comfortable? Still, if the patient is having any queries, though we have solved the questions, we have
ये
answered,
1 2 3 4 कंटिन्यू
they
करो
have any
सीरीज
questions. Are they feeling any other side effects? If
इसकी
they're
सीरीज
feeling any
कंटिन्यू करनी है
dizziness,
क्या
any
कि
weakness, any
मैं से
nausea. So in the
I
reassessment,
request delegates,
we
please mute yourself. It's disturbing the panel, please.
so
Thank you.
during thank you, ma'am. So during the reevaluation, even the other side effects or the other expected side effects needs to be addressed. And we need to provide the clear post-procedure instructions and reassurance. So again, I would repeat is about care, comfort and consent, anxiety and analgesia, reassess during the procedure, evaluate after procedure. And again, as a leader, we too need to check the patient's comfort. We can just do random audits. There are various tools that can be customized. We can use prompts, we can use frames. So wherein we will understand patient has experienced or what was the outcome of the particular procedure. So this also gives us an evidence as data talks. So this also would give us an evidence as what went well and what needs to be taken care of, or what preventive actions can be done. If there was any proactive comfort checks was done by the nurse, so that can be wherein there was an escalation done and because of which the patient felt comfortable. So these can also be appreciated and it can be debriefed in huddles so that one person's experience can be a lesson or a teaching or a knowledge experience for everyone. And while talking about the comfort of patient, we also need to focus on the comfort of nurses. A comfortable, a satisfied nurse will be in a better position to deliver a comfortable service to the patient. So, how many times do we also, as leaders, address a nurse's comfort? Whether is there anything that is concerning her? If there is a repeated concern raised by patient about a particular nurse's care or behavior, as leaders we should address them one on one and understand if there is something bothering. They would be in certain stress. When we personally have a talk with them, we come to know with how much personal stress they are coming into the hospital, and they're working with that. Just young nurses, hardly 22, 24 years, and they already have so much of stress. So while talking about patients comfort, we also somewhere need to consider and think about our nurses comfort, so that we have happy nurses and happy patients. Thank you, ma'am. That is from my side.
Thank you very much. And, you have given very, what to say, practical aspects that we should focus on from both the middle level as well as the frontline nurses. My next question is to Dipti. Just be brief. Most of the part is already covered by Savita. I would like to just list, because we have a lot of young nurses and they would like to remember, as Binsi was saying, something which is already pre-ready. So if you would just list some cues, some patients may not obviously show it, or how the nurse will be able to quickly pick them up, which will tell us that patient is really fearful and we need to intervene. Just
Thank you
list.
for the question. Yes, ma'am. Sure. Thank you for the question, ma'am. We have gone through the entire discussion, and now the crisp point is the nurses need to be very keen observer to assess all the verbal as well as non-verbal these clues in the patient behavior to assess the fear. Okay, the first thing is about verbal clues like asking question repeatedly or asking some vague question can be seen in the fearful patient. Second, about behavioral clues like patient can be restless at times or clinging the patient relative again and again, or sometimes asking the patient relatives to stay back although it is not needed. Sometimes you can see the emotional clues like or the psychological clues like fearful expression of the patient. Then physiological clues like increase in the heart rate or increase the blood pressure or sometimes increase respiratory rate without any obvious reason, or sometimes weird communication pattern or some like patient is not giving eye contact with healthcare workers can be seen, or sometimes the patient who is not communicating properly which when it is the questions are asked by the healthcare workers. And all these patterns can be observed specifically when the patient is hospitalized for the first time, at times when the patient is having any language barrier, or sometimes when the patient has any previous negative experience of previous hospitalization. So these are the prominent areas where we can see all this fear of the patient. Thank you.
Yeah, thank you for being very crisp, Dipti. I think my last question is to Binsi. I think we wish that everything goes well, but sometimes we may have extreme situations, a panic attack that can happen because of fear of unknown. So, how do we manage such extreme fear in our patients, and how do we ensure timely escalation? It is extremely important that we also prepare our nurses for some emergency that can happen due to fear of unknown.
Thank you, ma'am. Where a nurse can be found in like an overwhelming situation where all the patient relatives are asking her things and all. So it is very important as an organization, we should beforehand, we should be prepared for such a situation. So we need to have policies on identifying red flags, like just how Deepthi mentioned, all the red flags where there can be risk for patient or the patient relative getting super activated. So the others other than what Deepthi mentioned, there are situations like when there's a bad news that is bad news breaking that happens in the ICUs, or when there's a new diagnosis that has been disclosed, or especially among populations where pediatric population is involved and the parents are extremely anxious. So in such situations, the team leader or the senior nurses should be aware of the red flags and should definitely take action when they see some cues where the nurse at the bedside is distressed and is not able to answer to the queries of the patient relatives. So what can be done is, first of all, identifying the red flags, then having a very an escalation, a clear escalation pathway where the nurse knows whom to escalate in case of a distress like that. So if it's a new joinee, she can go to her mentor. All other nurses can go to the senior nurses like the team leaders or the educators or the in charges, and they can always receive help from them. And when it comes to clinical query, like for example, when the patient, the relatives ask about the clinical condition of the patient, the prognosis, etc. So this doesn't come under the scope of nursing practice. So the nurse should also be aware what she can disclose and what she has to delegate to somebody or take help from someone. So the team leader should be able to delegate certain concerns to the primary treating team, who can be helpful in giving the appropriate information, like Rajashri ma'am just mentioned. So the nurses should know what she can communicate and what is out of her scope of practice. So the nurses also should be empowered to escalate in difficult situations. She should not be fearful about any retribution from the senior team. And also the organization should follow a just culture, a safety culture, where the nurse feels free to escalate and not be judged because of anything. So these are the ways where the nurse who is not able to handle a patient situation can be helped, and easy escalation and resolution of conflicts can be done. And every moment of misery can be changed into moments of magic when the correct escalation happens.
Thank you, Binsi, for being very crisp and giving us the practical points. Looking at chat box, if there are any questions, we have time for our questions from our dear delegates, if they have any questions. So right now, I think I don't see any question. Sheetal Kamble to it. Okay. Any questions? Anybody? If I have missed anything? Any questions from our delegates? So
Can
to
I
yes,
can I just say one last line?
sure, madam. Yes.
Yeah, from last line from my side. Okay. So we have been talking about fear of unknown, right? डर के आगे जीत है. Okay, always remember this. And if I have to, how जीत कैसे करनी है? Appropriate, clear, timely, empathetic communication with hope. So it's ACTECH, acting. I can post it in the chat box if you want.
Yeah. So
Right.
any questions? I think I have also told our very esteemed panel to have a message, a one-liner. I think that works with Gen Z. Today we have a lot of Gen Z with us. So are there any questions? Anybody wants to ask any question to any of the panelists? We have the forum open for the question answer session. If there are no questions, I would give chance now to each panelist to share take-home message with one line. We can start with Rajashri. If anything else you have for the participants.
I think I just said what I wanted to say. That
Okay.
was the one.
Thank you. Then we
Yes.
go to Savita. If anything that you
Thank
have.
you so much.
Yeah,
Yes,
so
thank
as we've
you.
seen in the entire discussion, it was all about communication, and as Bisay ma'am also said, so communicate, communicate, communicate. Don't be mechanical. Communicate, and it will solve almost 80%. When the patient is like, patient feels that somebody is there to listen to me and understand me, that solves almost 80 to 90% of the problem. One thing is, so communicate. Second is, be that nurse that you would prefer to have if you were a patient, so be that role model. So that's it from my side. Thank you.
Thank you. Thank you. Dipti?
Yes, ma'am. The message from my side is awareness turn fear into strength. So be informed and be proactive. So this is the entire summary of the discussion which we have done in last 1 hour. Thank you so much, ma'am.
Thank you, Dipti. Vinci?
So, when communication is clothed with empathy, fear of unknown fades, and uncertainties can be changed into understanding. And also, timely escalation is not a failure of care, it is a crucial act of patient safety. Thank you.
Thank you, Binsi. And I'm sure the esteemed panel has done justice to this topic, which was very well chosen, very thoughtfully chosen by the Aina and Annie. So we trust that these Annie's efforts through Empower Hours that has been on for quite some time will boost courage in our nurses and prepare themselves to accept, understand, and help our dear patients, families to overcome fear of unknown. We are here as nurses to alleviate suffering, and we know that fear of unknown brings a lot of suffering, and also we help pave their way to healing and towards better health. Thank you.
Prajakta?
Yes.
Okay, I would just want to say two words. First is I have seen Shri Devi Balachandran on this group, and I'm so glad to see her here because I wanted to share one experience of mine from my this hospital where Shri Devi is working right now. You had asked a question to Savita regarding procedural fear of unknown, right? So I
Yes.
wanted to say there, ki when I was in this hospital in Muscat, where Sri Devi is right now, and I was a pioneer of OT. Pioneer means the first batch of OT nurses. And there, one protocol which we had to follow, I really worked very well, was the scrub nurse, the circulating nurse, who is for the patient next day, would visit the patient in the ward in their scrubs and introduce themselves to the patients and say that I am going to be a scrub nurse, I am going to be a circulating nurse. When you are going to come to the operation theater, you will see us. So, familiarity, the face was shown to the patient pre-operatively, how the surgeon and the anesthetist goes and meets the patient. The nurses were asked to go and meet the patients, and that worked very well. So that was one thing, fear of unknown, which I learned somewhere in my 1990s. And second is I wanted to ask Binsi, Sunil, this question of CCD. That gave me, I mean, with great humility, I'm going to share this. That gave me a great sense of personal satisfaction because this CCD module was, conceived in 2019 when we were, myself, Neelam, and Rosalind, we were our regional nursing heads. We had conceived this CCD module that time by ISBAR and LEAP and IDET was becoming, along with the HR, one, 3 days training program. So I wanted to know, Binsi, from you that you all are now experiencing that. You all are now implementing those modules as well. I'm sure a lot of changes have happened to that module because a lot of the new nurses have come, Gen Zs have come. You all know how to handle Gen Zs and all. How effective is these modules? I just wanted to get a feedback of something which we had done in 2018.
Ma'am, yeah, these modules are very effective, and it's a mandate now, like for all of our inductees, the Virohan batch that we call. It is a mandate that they have to undergo these 3 days of training. it doesn't guarantee that they will do whatever has been taught in the classroom, that they will do it in the clinical areas, because they very much get influenced by the existing team around. But then now, since majority, all of the nurses have already undergone this pattern of training, it has been effective. And our HR also has this, after 1 or 2 months, they do go to the clinical areas and go and check the effectiveness and check how the nurses communicate, and they score the nurses on the basis of their communication styles, like aid it mostly. And we also get the scores of individual nurses of who needs improvement and who is doing good at their bedside. So this module has been very effective for us.
So just for the group's benefit, I just want to add on, because we get nurses from a lot of different states and communication is definitely one of the barriers. So in this communicating care module, like for example, we had taken scenarios. IV cannulation was one of the scenarios which nurses do very frequently. So we had scripted how you are going to tell. It was a script given to the nurses in English, that first you will greet the patient, then you will say, I'm going to do this, I'm going to do that. So step by step you have to communicate. You are vocalizing your thoughts into words to the patient. So that is what this CCD was, and it's a wonderful thing. Durga, on your behalf, can I request Sri Devi to just share her thoughts?
Definitely, ma'am.
Yeah, she's one of our very senior people over
Yes,
here.
yes, yes, definitely. I was going to do that.
She's
Thank you
been my
for
teacher also at Hinduja.
Yes, yes.
everyone's teacher here.
A
Yeah.
BLS.
But my student. Okay.
Sridevi ma'am, I think, okay, yeah.
Because I do not have I'm at work and I don't have a speaker, so I came out of my office just to, since
We can
you
hear you very clearly.
yeah, requested me to talk. I didn't attend the whole thing, but I'm glad that, the young nurses are going in the right direction. Great job. Like she said, I have still got some gray hair, so those who don't know me will know me from that. No, communication is something that you cannot overemphasize in patient safety. Even what Kawaljit said about, Kawaljit is a year or two senior to me, I can't remember, but it's okay to call her by that name.
Of course, yes.
Yeah. So it's very important in patient safety to describe, like you all said, there is nothing new in this. And I'm a big fan of communication. You can over communicate a little nicely, your tone, your voice, and your body language conveys a lot. Not all need to be by words, but this will actually gain patients' confidence. So this is something very interesting in patient safety. Fear of the unknown is something, it's like so abstract. Like I am dealing now also in the ICU with patients here. I'm still very much in the critical care units. And we tell our students also, this is a nursing diagnosis, fear of the unknown, because your ICU patients
Yes.
especially cannot even talk. So identifying fear in the family and in the patients, whatever we do, honestly, I think it will not go away. It's like telling, don't get stressed and don't take tension. And it doesn't benefit anybody, honestly, but we try to calm our patients. So this is what we can do as best as we can. So even whether it's operation theater, even if we're going to give a small injection, patients will have fear of the unknown. Sometimes patients just retract their gluteus or their hands, and then you are in the wrong area even. So it's something that is very good as a topic, and they have told in the correct way, but how much everybody will do will depend on their own understanding and their own empathy and their own, like, who was it? I don't remember her name. She said, be the nurse that you would like to have for
Yeah.
yourself. At least all
Savita.
of us are
Yes.
yes. Thank you so much for just having me on. I just had a few minutes today, so I thought not the always there, but these timings are very odd. We are 1.5 hours behind,
I
and this
know.
is actually hours, and we work on Sunday, Monday, everything. So nothing suits me, honestly. Thanks, Kawaljit,
Thank you.
Yeah.
for encouraging.
Thank you,
Thanks.
ma'am.
I'll
Welcome,
come.
Thank
welcome.
you,
Thank you, ma'am.
Sridevi madam. So
Thank you so
I
much.
just end with 2 lines, because we spoke about vulnerable patients, and even the patient safety first came for patients. So I would like to end this panel, which I was really touched. This is from 2006. It was my first posting, I mean, in US hospital. So over there, they are very, very standardized, and we are also in that journey of accreditation. So they had a rapid response team where we were oriented 1, 2, 3, 4, 5, 6. If you see this, you activate rapid response team. And they had the last one in that, where I'm trying to relate this to today's panel discussion, the fear of unknown, which the nurse is not able to identify. It is just nurse's intuition that she feels that her patient something may go wrong, and she was empowered to call rapid response team even if it didn't fit into 1, 2, 3, 4, 5. And it was over and above that, nurse was given importance that because she is fearful something may go wrong with her patient, she has called the team and she wants the collaborative effort to identify that what may go wrong, and it was her proactive intuition. So that is what I would like to even share with the team and panel and the delegates, that this really made me feel that yes, that nurses observation assessment, if even if she's not able to name it, it has value. So I think that's a
Wonderful.
journey. Yes, it's a journey to even empower the nurse to acknowledge her own fear about patient,
Absolutely,
to
absolutely. Very
ensuring
important.
that the patient is given that due attention by all the team members, which the rapid response team would bring in. So collaborative effort.
Excellent.
Thank
Thank you, Prajakta, and thank you all the panelists.
Ma'am, Pearl ma'am has
Pearl
raised
wants.
her hand.
Oh, sure,
Pearl,
sure.
Pearl wants to speak something.
Okay, okay. Is she there?
I'm,
Oh,
I'm
yeah,
Yes,
here.
I
yes.
can
I'm
see
here,
her.
Durga.
Thank you, Pearl,
Hi.
for joining in.
No, I'm very happy to actually thanks Durga for sending the reminder, because I just landed at work and then I saw Durga's message and I said then I should sort of join, because I knew that the panel consists of all young nurses whom we have seen, many of them being groomed when I was probably working at Fortis and other places. Now them at UK, and because this was all about communication and patient safety, I would definitely place one thing. Of course, we are advancing in India. A lot of things are changing. But to be honest, when I look at nurses here, and the amount of time they spend communicating with their patients is far much greater than what we do in India. We are following probably checklists and tick boxes, but our nurses really do not have time to take care of patients. One thing probably because all the responsibility falls on nurses. Unlike here, where everybody has their own set of responsibilities, nurses will do their bit. The rest are responsible for the patients. I think that's one paradigm shift that we need to probably work at for in India. I work in a very different role. I do cancer research. One thing I would like to probably say here in cancer research, when it comes to patient safety on that perspective, every time, although my patient consents, before my patient consents for the research study, the doctors will explain everything. The nurses then will separately sit in the clinic and explain everything. I mean, like I think ma'am said, Shridevi ma'am said, over communication is not bad. And that's what we keep on doing. And every time when we have a patient's clinic visit, we'll always ask the patient, are you happy for me to continue with this trial? Because patient can withdraw the trial anytime that the patient wants. But that's the first thing that we will always ask our patients. And I think these are a few bits, I think, which are just, I don't know what's in the training of the nurses here. They do not train so elaborately like us. Shridevi ma'am knows this very well when she was on my podcast. She's not a person who fancies, I think 6,000 plus hours of nursing education in India, vis-a-vis just 3,000 hours
Wow.
in Dubai and in the
Wow.
Saudi countries and
Correct.
UK. They do only three years of nursing. They specialize and they come as midwife, or they come as a pediatric or adult nurse.
Right.
Unlike us, we specialize in everything, which is good. But I think what also happens is they choose what they want to do and they specialize in that. And communication is so much ingrained. Also, the fact that probably they all speak English here, they do it well, and that's the part of life. But I think communication is just ingrained in. That's what I'm learning from young nurses here. It's just ingrained in the way they teach, treat the patient. The first thing would be to wish the patient and check if everything is fine. And I think I like this word when they use, "Are you happy for me?" That precedes everything. Are you happy for me to give you this injection? I found it funny initially, but I think it's become a part of my vocabulary now. Are you happy for me to go ahead and do this for you? Are you happy for me to give you a sponge bath now? Okay. Are you happy for me to turn you around? And they will not do unless the patient says yes. The
Okay.
Vodafone punchline was happy to help. And Vodafone is, and I used to always wonder where it comes from. My husband is in advertising. I always wonder how these catchphrases come. And Vodafone is a UK brand. So happy to help or happy to do something is so much ingrained in them. And probably that's one key takeaway I would probably leave, with everybody saying, are you happy for me to do so and so? And I
Good.
think that just re-emphasizes the communication again and again. That's one thing which came in my mind. Sorry, I attended only half of the session. Like I said, I mean, it's about 8:40 now here. Yeah. So that's all. Sorry, don't want to take much of your time, but thank you for allowing me to talk.
I think Pearl is about the theories that we learn in our first year nursing. We learned about locus of control. So
Yeah.
when we give the remote control to our patient to whatever level possible, they are happy. If you take their permission, even if you are not able to do it, you have to take their permission, whatever you do.
Yeah.
That
Yeah.
one thing was very obvious even in my stay in US. Patients, they feel important that the nurse is taking my permission before she does anything for me.
Yeah.
And she
And
confirms.
and there is mental capacity which you have to assess. Every nurse
Yes.
has to assess. If you feel the patient is not capable enough to respond to you, and then they're put into another way of dealing,
Yeah,
where
it is,
the
yes.
healthcare workers can take decisions for them. But that's like a complete different level of assessment and evaluating that. But anyway, I don't want to take much of your time. So thank you so much.
Thank you,
Durga,
Pearl.
thank you
Thank
for
you.
letting me
Good to
know
hear
about
you,
this
Pearl.
important
Good to hear
thing.
your tagline. It's wonderful.
Thank you.
Thank you,
Thank you
ma'am.
to everyone who made it possible to join this Empower Hour. Definitely, this is a topic which would require part two and part three and part
Yes.
four. And I think we have triggered a thought for everyone and everyone to work on it. So definitely, I would say that this selecting this topic for Empower Hour has definitely helped, and a lot of effort put in by each and every of our panelists, Miss Prajakta, Miss Savita, Madam Rajeshri, Miss Dipti, Miss Binsi. Thank you, because all of you are working, you all have prepared for this panel discussion and have given justice to each and every question which was asked to you. So, a deep gratitude to all of you on behalf of the entire Annie team. And let's work together to help patients overcome this fear, and moreover, help our nurses also to overcome their fears. So, wishing you a great day ahead. And thank you everyone for joining us. And those who are here, those who have been part of this panel discussion, who have participated as delegates. And if you are still not a member of Annie, please go ahead and get yourself your membership today. I promise you, you will not regret being an Annie member, because we have so much to share over here, and so many who are so happily sharing over here. You will definitely benefit. The student nurses will benefit after they pass out from after they graduate from their colleges. And all those who are in this nursing fraternity, Annie is an opportunity to give back to your profession. So, very happy day to all of you, and thank you so much for joining again. With this, I end the session, and once
Lastly,
again,
ma'am, lastly, may I
Sheetal,
request everyone to put your camera on so that we
yes,
can
yes,
clip this momentum.
let's take a group picture. Uh, hold on. I'll just
Pearl,
take this. I'll
Pearl,
take the
and
spotlight on off, so that everyone is seen on the screen together.
Pearl can join.
We still have people joining in for the session. Okay, everyone, please come on your screens so that we can have a group picture of this Empara. Okay, Sheetal, go ahead and take it on both the screens.
Just a few moments.
Is it done?
Just a minute, ma'am. Just a minute. There are 3 screens. Just a minute.
Done?
Yes, we have done, ma'am. Thank you so much.
Wonderful, wonderful. Thank you,
Thank you,
Shobha ma'am,
everybody.
also for joining. Thank you, everyone.
Thank you.
We
Thanks,
sign off.
everyone.
Thank you, everyone. Thank you
Thank
so
you,
much.
Madhvi. Thank you, Simple.
Thank you, everyone.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Durga, you can end the